So I'm Becky, and I'm one of the plastic surgery residents. I'm in my 4th year, and thank you so much for letting me speak today at your Grand Rounds. I'm really excited to be here. My talk is called Skip the Surgeon, and I'll be chatting today about the Calgary Kids Hand Rule. So it's a prediction model for pediatric hand fracture triage. And today during this webinar, there's no mic access for the rest of the participants or chat function, but the Q&A will be open and we can address all of the questions at the end of the talk. So the agenda for today, or if you will, the menu, it'll be broken down into 3 main components. So first, past work. So why we made the Calgary Kids Hand Rule and how we made it. And then current work. So here I'll talk about 2 ongoing projects we have, one at the Alberta Children's Hospital with our prospective trial on the Calgary Kids Hand Rule, as well as our external validation studies. And then finally, I'll wrap up with a quick blurb about future work, hopefully hitting on a couple of studies we'll be starting in the next year or 2. So first, let's talk about the why. So why do we need a hand rule? Well, it turns out pediatric hand fractures are common. They're very common. And the hand is the most frequently injured body part in children, with hand fractures ranking as the 2nd most common fracture in kids, accounting for 1/5 of all pediatric hand fractures. And the incidence of hand fractures actually increase with age, with peak occurrence coinciding with the onset of puberty and an increased participation in contact sports. And at the Alberta Children's Hospital, at ACH alone, there are 600 pediatric hand fracture referrals each year to our plastic surgery team. So that works out to about 1 to 2 referrals a day, and each patient requires, on average, 2 visits with the plastic surgeon. So this ends up being a large clinical volume for a relatively small pediatric plastic surgery team. It's well established that most pediatric hand fractures can be successfully managed with immobilization alone. And we previously reported that less than 10% of pediatric hand fractures required surgical intervention, and the vast majority experienced no change from initial management. And so the patient flow for pediatric hand fractures at ACH, it looks something like this. A pediatric hand fracture will come into the emergency department, and that child is triaged by the emergency physician, so by you guys. And then through direct fax referral system, the plastic surgeon's made aware of the patient and triages him or her within 24 hours. And as I mentioned before, there are about 600 referrals a year, or about 1 to 2 referrals a day, each with about 2 visits. And so this all boils down to a lot of strain on the plastic surgery side of the system. Potentially a waste of funds, given that most fractures do not require a change from their initial management, and an increase in plastic surgery wait lists for other non-urgent hand fracture patients. And our current wait list times to see a pediatric plastic surgeon for non-urgent consult is about 9 to 12 months right now. And so this all led us to start thinking, is there a better way? Is there a way to triage these pediatric hand fractures and separate out the simple fractures from the complex ones? Because really, it's the complex ones that are the fractures that need to be seen by a plastic surgeon. And then perhaps the simple fractures could be managed by non-subspecialists. And I'll define what simple and complex means in more detail later in the presentation. But for now, you can just think of it as complex being needs referral to a plastic surgeon, and simple could be managed by non-subspecialists. But really the crux of the problem is that triage part. Triaging between a simple and a complex pediatric hand fracture remains quite challenging for many primary care physicians. And that's demonstrated by the wide range of referral patterns reported into literature, all the way from 10% up to 100%. And this isn't without merit. I mean, children represent a specialized subgroup of patients with unique needs. But we thought perhaps we could help emergency docs in triaging kids with hand fractures through a prediction model. And we knew that if we were to make such a prediction model, we'd have to ensure that it was safe. Because when we talked to our emerge doc colleagues, they were concerned about their patients' hand function and growth potential and where these patients were going to get follow-up. And we knew from a downstream point of view, if we were to make such a prediction model, we would have to ensure that the non-subspecialists were equipped to manage the simple pediatric hand fractures. And as ambitious as this project was, we thought, here's something that we could really study, improve upon, and make a clinical impact. And it all really comes down to this slogan that you've probably heard before in healthcare: getting the right care to the right patient in the right place at the right time by the right provider. So that's the why we made the Calgary Kids Hand Rule. So pediatric hand fractures are common. There's a lot of them, and most do not need specialized care by a plastic surgeon, let alone surgery. And we saw this as an opportunity to improve triage. So now I'd like to talk about how we made the Calgary Kids Hand Rule. So when we first had this idea of making a prediction model for pediatric hand fractures, we instantly started thinking up of memories of the Ottawa ankle rules and the Canadian CT head rules. And these famous prediction models, they're really slick examples of well thought out and well-derived prediction models, and they're Canadian to boot, which is nice. But behind all of that shiny exterior, there was a lot of rigorous research that went into creating those prediction models. And prediction models, like a lot of other methodologies, actually have well-defined steps to making them. And that's starting with deriving or creating the model, then proceeding to validation of the model, both internally using statistical methods such as split sampling or bootstrapping, and externally by testing your prediction model in different data sets. The next step is impact analysis, and then finally, long-term implementation studies. Now, even though each one of these steps represents a large research project on its own, nonetheless, prediction models are gaining popularity, and even in the pediatric literature. And so this graph is just from a systematic review on pediatric prediction models, and shows that each year that they looked at, more and more prediction models for pediatric patients were being reported in the literature. However, when you look closer at prediction models for kids, 76% of the models never make it past step one, the derivations stage. And there's a couple postulated theories for why this may be. And those include the fact that with kids, there's a lot of uncertainties in communicating with and examining children. And this can create bias in your predictor variables. Another reason may be that parents and physicians have high expectations regarding not missing important diagnoses. So kids represent a specialized set of patients in that way. And finally, validation studies for prediction models in kids have been reported to take 2 to 3 times longer, all other things being equal. So needless to say, embarking on a prediction model for pediatric hand fractures was looking pretty daunting at this point. But I think there's a certain amount of pain and punishment really that all residents secretly enjoy. So I decided to proceed anyways. And of course, by I mean we. So we put together a core group of people, and here they are. So a PhD statistician, Peter Ferris, a PhD methodologist with experience in prediction models, Paul Ronksley, and 2 pediatric plastic surgeons, Rob Harrop and Frankie Frolin. And we all got together to tackle this idea of a prediction model for pediatric hand fracture triage. And the other thing, to top it all off, I did a master's in epidemiology at the University of Calgary through the clinical investigator program. And that just helped me gain the skills I needed to really work on the statistics side and epidemiology side of this prediction model. So the objective for my master's thesis was essentially the beginning of creating this prediction model. It was to derive and internally validate a prediction model for complex pediatric hand fractures. And before I go any further, you're probably like, okay, Becky, tell me what the complex fracture actually is. So I can tell you now the nitty-gritty of the complex fracture. And we want the complex fracture, remember, to represent a fracture that would require referral to a plastic surgeon. So we defined a complex fracture as any fracture that needed close reduction, close follow-up, defined as 4 or more plastic surgery appointments or surgery. So we said all of these types of fractures would need to see a plastic surgeon. And on the flip side, a simple fracture was any fracture that did not need these things. And then to actually derive the prediction model, we performed a retrospective cohort study of consecutive hand fractures referred to the pediatric plastic surgery team at ACH over 2 years, so January 1st, 2013 to December 31st, 2014, and we collected data on 21 candidate predictors. We used logistic regression with bootstrapping to derive our model, and we found that there were 6 significant predictors for our model for predicting complex pediatric hand fractures. And they were angulation, condylar involvement, dislocation or subluxation, displacement, open fractures, and the presence of rotation on physical exam. And we'll go over those a bit more in detail through examples in the near future. So after we had made this logistic regression model, we then had to test our model's performance. So first we tested discrimination. That is, can your model, or can our model, tell the difference between a complex and a simple fracture? And our model had strong discrimination with a C-stat of 0.88. Next, we tested calibration. So that's the ability of our model to accurately predict the risk of a complex fracture. And this is a Cox calibration curve. And it shows that our model reaches near perfect calibration as the blue line, which is our model, nearly mirrors the green line, the ideal prediction model. So our model performance was strong. And next, we needed to translate our prediction model into a scoring system. So we used the Framingham method to translate the regression coefficients into the regression coefficients of our 6 significant predictors into a weighted point scoring system. And that's what you see here, where each predictor, angulation, condylar, dislocation, etc., and its subsequent categories, so absent, mild, moderate, severe, each of those gets assigned a number of points that correspond to the magnitude of its beta regression coefficient from the multivariable logistic regression equation. So then, if a fracture comes in that looks like this, so something like a bony mallet, you look at each of the predictors in turn, and you decide which category the fracture fits into, and then you add up all of the points. So for this fracture, it would have a total of 8 points. So great. But then when you try to relate that 8 points scoring system back into the patient flow, things get a bit confusing. Like, what does a fracture with 8 points really mean, and how does it work into the clinical care pathway for this kid? Does 8 points mean that the fracture is complex and should be referred to the plastic surgeon? Or does 8 points mean that the fracture is simple and should be managed by a non-subspecialist? So what you need to do for prediction models when you have a scoring system is you need to make relevant, how you make it relevant is to make a cutoff, whereby if the patient has a total point score that's above the cutoff, then you could send them down this part of the pathway. So for us, then the patient would be classified as complex and be referred to the plastic surgeon. And then again, alternatively, if a patient has a total point score below the cutoff, then the patient will be classified as a simple fracture and can be managed by a non-subspecialist, such as a family doctor. So now the interesting part, how do you pick your cutoff? Well, the easiest way to look at it and to pick your cutoff is actually to look at all of your different possible points cutoffs and then compare them and all the performance. So just for theory's sake, if you pick a points cutoff as 0, every single fracture is predicted as complex. And then the sensitivity of the model is 100%. On the other end, the extreme end of the spectrum, if you set the cutoff to the maximum number of points, so to 19 points, no fracture is predicted as complex, and the sensitivity drops down to 0%. And then here's our model performance for some selected other points cutoffs. So that gives you an idea of how our model performs at these different cutoffs, but kind of still leaves you with the question, how do you pick your cutoff? Well, it turns out an important performance benchmark for picking a cutoff is a sensitivity greater than 95%. And why greater than 95%? Well, it's been argued that most physicians would not tolerate missing more than 5% of the outcome. So they wouldn't want to miss more than 5% of complex fractures. And in our model, looking at the different cutoffs, you'll see that a sensitivity greater than 95% corresponds to a points cutoff of 1. So if we pick our points cutoff at 1, that gives us a sensitivity of 96% and a specificity of 45%. Now there's something really interesting about picking a points cutoff of 1, because when you pick a point cutoff of 1, that means that when you see a fracture like this, instead of assessing the fracture by adding up all of these different points, what you can actually do is use a tool with tick boxes, because the number of points doesn't really matter anymore when you have a points cutoff of 1, because the presence of any one predictor, no matter how mild or severe, would automatically garner the fracture at least 1 point. Thus, when you have a point cutoff of 1, you can use tick boxes. So instead of counting at points for each predictor, if any predictor is present, you tick the corresponding predictor tick box, and the fracture is automatically classified as complex. So again, the threshold of 1 point, it makes for an incredibly simple, easy to use prediction model. And as a referring physician, using a prediction model with only 6 predictors, so 2 from physical exam and 4 from x-ray findings, where all you need to do is tick a box, we're hoping makes for a really accessible and usable tool. So that's how we made the prediction model, the Calgary Kids Hand Rule. And now let's look at some practical examples of how to use the Calgary Kids Hand Rule. So we'll just go through some x-rays together. And this might be some examples that you've already seen in clinical practice. So for our first example, this is an AP x-ray of a right hand. And the blue arrows here are going to show the fractures. So you can see 3 fractures of the 2nd, 3rd, and 4th metacarpals, and these are metacarpal shaft fractures. Now, when you look at the corresponding Calgary Kids Hand Rule, and you start looking at those 6 predictors and thinking, are any of these predictors present? You're going to look at this fracture and you're going to think, well, these fractures look like they're displaced because the fracture fragments has splayed apart. And now if you're doing a physical exam on this kid as well, you could imagine that maybe the kid's fingers, when you're asking them to make a closed fist, maybe they overlap or scissor. So maybe malrotation is present. So that's how you would use the Calgary Kids Hand Rule for this fracture. You would tick off those predictors. And then because you've ticked off any predictor, it automatically means that this fracture is classified as complex, and then they should be referred on to a plastic surgeon. So here's our next example. This is an x-ray of the left thumb, and this is a Bennett's fracture. It's an interarticular fracture at the base of the thumb metacarpal. And that blue arrow again shows you where that fracture is. And these fractures actually are inherently unstable because the AB, the abductor pollicis longus, pulls on the metacarpal and subluxes the thumb away from that small, stable fragment piece. But really, you don't need to know any of that in order to use the Calgary Kids Hand Rule. All you need to do is to assess the fracture and look at the x-ray and tick off the corresponding predictors. So here I've ticked off subluxation and displacement. And honestly, even if you did not pick up that this fracture was sublux, if you saw that it was displaced, you would still be able to tick off the appropriate box of displacement, and the fracture would be classified as complex, and this fracture actually would likely need to go on to have surgery. So our next example is shown here with an oblique and AP x-ray of the right little finger. And here I've pointed out the fracture again. So this is a Salter-Harris 2 buccal fracture of the right 5th proximal phalanx. Actually, none of the predictors are really present here, so no boxes are ticked. And this fracture would be classified as simple and potentially a good fracture for a non-subspecialist to manage. Now, one of the things that we did look at when we were deriving and creating this prediction model was epiphyseal or growth plate fractures. And we looked at growth plate as one of our candidate predictors to include in our prediction model, but actually it wasn't significant. I think this is quite interesting because it's a common concern in the literature and from emergency doctors. Will this fracture that goes through a growth plate, will it affect the potential growth of the child? Will it stop the digit from growing, or will it grow at a crooked angle? Well, it actually turns out that probably bad growth plate fractures, so epiphyseal fractures that will result in growth plate arrest or growing in a differential angle, they usually have other predictors present. So they're usually also displaced or angulated. And the non-worrisome growth plate fractures, so epiphyseal fractures that'll go on to heal just fine, they actually don't have any other predictors present. So that's just something to know and something for you guys to know that we did consider in our prediction model, but actually just didn't come out as a significant predictor. So another example here, this is an X-ray and it's an oblique view of the left fourth digit. And this is a unicondylar fracture of the proximal phalanx. That's a bad fracture. And here you might see on a physical exam that the child has malrotation, so maybe their fingers overlap. It involves the condyle and it's displaced. You can see the fracture fragments are apart. Now I know one of the concerns always is a quick reminder about what is a condyle. So if you're looking at just a hand here, the condyles are those little knuckle-like projections on the distal aspect of the proximal and middle phalanges, and they articulate with the base of the bone just distal to them. And they're important structures for the integrity of the joint. So it's not surprising that that predictor is significant and predicts a complex fracture. So again, if we're looking at this fracture, the unicondylar fracture, there's quite a few tick boxes, but again, any one tick box, if that's ticked, the fracture will likely go on to need surgery. So here's our last example here. So we're looking at the right thumb, the AP view of the right thumb. And here's the fracture. So you can see this faint fracture line going through the metacarpal. And no predictors are present. And so this fracture is classified as simple. So potentially could be managed by a non-subspecialist. So back to our patient flow diagram and our proposed care pathway. So again, if a child comes in with a hand fracture, hopefully now you have a better idea of how to use the Calgary Kids hand rule. And after triage with the Calgary Kids hand rule, if the emergency department physician doesn't tick any boxes, finds that none of the predictors are present, then the fracture will be classified as simple. And in the proposed pathway, it could be managed by a non-subspecialist. Alternatively, if a child comes in with a hand fracture, and after triage with the Calgary Kids hand rule, the emergency physician ticks off even one of those boxes, the fracture is classified as complex. And in the proposed pathway, it would be referred to a plastic surgeon. So that's the summation of our past work. That's the how of the Calgary Kids hand rule. So we made the Calgary Kids hand rule using multivariable logistic regression, and we created a prediction model with strong performance. And we ended up choosing a cutoff of 1 point in order to reach that benchmark of greater than 95% sensitivity, which meant that we could translate the model into an easy to use tool with tick boxes. So back kind of to our agenda or menu, we've chatted about past work. And now what I'd like to talk about next is current work that we're doing. So we'll chat a little bit about the Calgary Kids hand rule validation studies that are currently on the go. So if you remember looking back early in the presentation, we talked a little bit about the methodological steps for the Calgary Kids hand rule and really for any prediction model. So far we talked about deriving the model with multivariable logistic regression. We also internally validated the model with a statistical technique called bootstrapping. And these results have been written into a manuscript, which is currently under review with the editorial board of our plastic surgery journal called Plastic and Reconstructive Surgery. And so the next step for us would be to further validate the model. And I suppose that kind of begs the question, why do we have to externally validate prediction models? Or at least that's what I thought and felt like after my master's was completed. I mean, haven't we already proven that this prediction model works well, and we've used fancy statistical methods, and we have good model performance, so why do we need to do more? Well, internal validation and all of the fancy stats like bootstrapping, that really only tells you how well your prediction model performs in the original population sample. So for the Calgary Kids hand rule, we know our prediction model performs well in pediatric hand fractures in Calgary during January 1st, 2013 until December 31st, 2014. So it's a very specific group. But you have to ask yourself, what if the tool did not perform well in other settings? What if the Calgary Kids hand rule didn't work for, say, pediatric hand fractures in Calgary during 2019? Or you want to prove that the Calgary Kids hand rule works in Edmonton or in Boston or in Dubai? So this idea that the tool only works well in the original data set, or in other words, a tool that's overfit to the original data set, that's called optimism. You don't want to make a tool that's over optimistic, because that means the tool is only good for that original data set. So for us, it would only be good for pediatric hand fractures in Calgary during 2013 to 2014. So what you want to do is validation studies. You want to prove that your prediction model is generalizable, that it's not over optimistic. You want to prove that your prediction model can be used in lots of different scenarios. And that's why you do validation studies. So our first of two validation studies is a prospective trial at the Alberta Children's Hospital, and that's going on right now. And this is a temporal validation, because essentially the only change from the original data set is the prospective nature of the data collection. It's a different time frame, hence temporal validation. And as I previously alluded to, when a child presents with a hand fracture to the emergency department at ACH, the emergency department physician uses a fax referral form to directly refer the patient to the plastic surgeon on call. The plastic surgeon then triages the fax referral within 24 hours and usually sees the patients within a couple days. So we already had an infrastructure set up there for emergency department physicians to access plastic surgery care. So what we did for the ACH prospective trial is that we embedded the Calgary Kids Hand Rule into the fax referral form. And the thought being, if ACH emerge docs are already reaching for this fax referral form when managing a pediatric hand fracture, let's just use that same infrastructure to get our Calgary Kids Hand Rule, our prediction model, into that process. And again, just want to emphasize that this is a quality improvement study at this point. So there's been no change in patient care. So all of this pathway that I've been talking about, where complex fractures are managed by plastic surgeons and simple fractures are managed by non-subspecialists, that's just theory right now. We're essentially just shadow trialing the prediction model, and every patient is still getting the standard of care. They're still seeing the plastic surgeon. So for this prospective trial, essentially the methods are looking at the predicted outcome of the Calgary Kids Hand Rule versus the observed or actual outcome. And we've actually been running this study now for over a year, since April 1st, 2019. And we collected follow-up data on all of these fractures for 3 months since the initial referral date. And how we looked at the performance was we looked at sensitivity, specificity, and C-stat. Now, unfortunately, due to COVID-19, we actually don't have updated results for you today. So the data that I'll be showing you in the next couple of slides is on kids referred from April 1st until September 1st, 2019. And so they have follow-up until December 1st, 2019 in these slides. So here are the results of our Alberta our Calgary Kids Hand Rule ACH prospective trial. The results up to September 1st. And those are shown in the far right column titled Prospective Validation. So in the prospective validation, up for the follow-up to December 1st, we have 205 patients. And then you can see how this compares with our original data set from the original retrospective derivation cohort. And the original cohort, we had 1,171 patients. And so for the prospective trial, right now for the data we have, our sensitivity is sitting at 90%, which means we're missing 10% of complex fractures. We have a specificity of 73%, which means we're identifying 73% of simple fractures. And we have a C-stat of 0.82. And remember, really, any C-stat over 0.7 is considered useful and good for prediction models. And so that was our ACH prospective trial that's ongoing. And now I'd just like to chat with you guys about our external validation studies, or geographic validation, because we're giving our hand rule away to other centers to see how it works. So currently underway, we have 2 external validation studies, one at the Children's Hospital of Eastern Ontario in Ottawa, and one at the BC Children's Hospital in Vancouver. So our ethics have been approved at all 3 sites, us included, and the data collection is underway. So both CHIO and BC Children's, they're going to produce data sets of pediatric hand fractures for us. And we're then going to test our Calgary Kids Hand Rule on it. And just like the ACH prospective trial, we'll compare the predicted outcome with the actual or observed outcome and measure the model performance with sensitivity, specificity, and the C statistic. Okay, so now going back to our agenda here, we've talked about past work, our current work, and now I'll finish up with some of our future work. So right now, I've been showing you this flow diagram of the patient care, and we have a general idea of how we envision this pathway working, with patient flow going through the emergency room physician, triage being aided by the Calgary Kids Hand Rule, and then simple fractures being managed by a non-subspecialist, and complex fractures being referred to the plastic surgeon. But that's an ideal pathway. And it's really quite a far cry from the current situation, which can be represented by this complicated flow diagram, whereby patients can bounce around to many different providers before reaching their final destination and management plan. So patients may come to a family doctor and be triaged, and then go over to urgent care center or to emergency department, whereby maybe a couple of them are managed there. Sometimes they fail the management, and about 600 of them come down to the plastic surgeon eventually. But this can take time, and patients and their families may have to see several providers. So what we need to do as part of our future work is to try to get from the current pathway on the left side of the screen, and then all the way over to the proposed pathway on the right side of the screen there. And so the first study we'll be undertaking in the near future is a qualitative study. What we need to do is engage stakeholders, so emergency department physicians, patients, the occupational hand therapists, and we need to conduct focus groups to identify the barriers and facilitators from going to the current pathway on the left to the proposed pathway on the right. And then we need to use this information to create an updated pathway. And then once we have that updated pathway, the next step will be to implement our updated pathway at different centers. And this is an impact analysis. And we'll likely be using a stepped wedge design for impact analysis, whereby you study your chosen outcome for a set period of time, and each center has its own starting time where the clinical care pathway is implemented. So this is essentially like a randomized controlled trial, but it's done in a more efficient manner because you're not just looking at single patients being randomized, you're looking at centers being randomized. So it's on quite a large scale. And each center acts as its own control, as you can see in the white box here as the control periods. And each center also acts as its own treatment arm, so these green boxes here. So those are the two studies that we currently have that we're thinking about engaging stakeholders and writing up grant proposals for. And so that kind of brings me to the end of talking about the Calgary Kids Hand Rule. So we talked about the past work, the current work, and the future work. And I'd just like to highlight some of the takeaway or take-home messages for you about the Calgary Kids Hand Rule. So first, we created the Calgary Kids Hand Rule, which is a prediction model for pediatric hand fracture triage. And we created this prediction model in a statistically rigorous method, and we worked hard to make it clinically relevant. With a point cutoff of 1, we're able to convert our prediction model into an easy-to-use tool with only 6 predictors, whereby an emergency department physician simply has to tick off boxes in order to classify a fracture as simple or complex. And we've been running a qualitative study improvement at the Alberta Children's Hospital for over a year now, and the results from this prospective trial have been promising and actually have informed us about how to make our tool simpler and easier to use. And our external validation of the Calgary Kids Hand Rule, it's underway right now in both Ottawa and Vancouver. And we've also mapped out our next future studies for the Calgary Kids Hand Rule, which includes a qualitative study to inform an updated care pathway, as well as a multi-center impact analysis in the future. So ultimately, these efforts should yield an informed patient-centered care pathway for pediatric hand fractures that would enable more efficient use of healthcare resources, provide appropriate services and interventions in a timely manner, resulting in improved patient outcomes for this population. So that's really the goal, getting the right care to the right kid or the right provider in a timely fashion. So thank you very much for your attention. I feel very lucky to have spoken to your group today about the work that we're doing, and a very special thank you to the whole team involved in this project. So that includes Altai, Mo, Dr. Frolin, Dr. Harrop, Karen Hewlin, Dr. Ronsley, Dr. Ferris, Kaylee, who is actually one of your Emerge residents. She's helped out with this project earlier. Dr. Lamb, Dr. Temple Oberly, and James Wick. And so this is the end of the formal presentation. And I'm happy to take questions now. And I see that there are some questions in the Q&A. So I'll just open that now and do my best to answer these. Just one moment. Okay. So one of the first questions that I have is, did you look at inter-observer agreement, so CAPA, for both the predictors, physical exam and x-ray findings, and for the outcomes, needed close reduction, operation, or frequent follow-up? So we did a couple things in order to answer that question. So there is some literature written about some of the predictors that we chose. And I think specifically there's poor inter-rater reliability when you look at your x-ray with regards to angulation of fractures, as well as displacement of fractures. And what they found was that people couldn't really tell within 20 degrees how angulated a fracture was. And so we were quite concerned about that predictor at the beginning. But what we found was that kind of became a moot point when the points cutoff got picked at 1. Because now, instead of having to assess predictors like angulation by measuring out your x-ray and looking at the degrees of the fracture, all you had to do now was tick a box. So is there any angulation present? Yes or no. And we found that this actually made using the predictors a lot more user-friendly and easy, and decreased that inter-rater poor reliability. The other thing that we did too with our ACH prospective trial is that we looked at how the plastic surgeons use the form and how the emergency physician used the form. And if you just give me 1 second, I can actually bring up some of that information here for you. So when we looked at how the emergency doc used the form and how the plastic surgeon used the form, we found that some of the predictors that they had good inter-rater reliability it's classified as moderate, with the condylar involvement and dislocation or subluxation. So both plastic surgeons and emergency physicians had good moderate inter-rater reliability for these, which actually was a bit surprising, because I know condylar involvement's often a predictor that people get quite anxious or nervous about. And then when we looked at the inter-rater reliability between emerge docs and plastic surgeons using some of the other predictors, we had moderate to substantial kind of inter-rater reliability, so a bit lower on some of these. But in general, the outcome, so whether or not the plastic surgeon said the fracture was complex, whether or not the emerged physician said it was complex, and the concordance of those two, that was really strong. So I think that probably all comes down to the fact that using the tick boxes is actually quite straightforward. And so it takes away some of that difficult inter-rater reliability of different predictor models. Okay, so that was one of the questions. I will take that one off. Another one of the questions is, the challenge for me is that non-surgical does not mean therapy is not required to reduce morbidity for fractures. Is this considered in the referral pathway? Oh, great question. So I think when what we're working towards right now is to try to clarify the pathway, especially for the simple fractures. So if I bring up the proposed pathway, so this simple fracture pathway, which is represented from the green circle here, we actually have kind of left it up to interpretation at this point. So for simple fractures managed by a non-subspecialist, right now we have some options that we're thinking of: a family practice physician, an urgent care center physician, or even a hand therapist, so an occupational therapist. Because just talking with some of the emerge colleagues that have been participating in the Alberta Children's Hospital QI prospective trial, there's been a major concern. Sometimes emerge doc or urgent care physicians, they want to refer the patient on to plastic surgery, not because they think the fracture needs surgery, but because they want a specialized splint that they want the child to be comfortable in, to be able to take on and off, to be able to wash their hand. And so we heard some of that, and we know specialized splinting is a big concern. And so that's why the hand therapists are a potential provider in our simple pathway. And we work quite closely with the hand therapists at ACH. So they are involved in this project. Karen Hewlin, one of the people that I acknowledged in the end, she's on the project. And I think really for our qualitative study, looking at the barriers and facilitators to getting to this proposed pathway, I think one of the main focuses in this qualitative study will have to be the focus groups and talking to everyone about how they envision the simple arm of this pathway to work and how we will get all the splinting that's needed for the patients. The next question. So this question says, you noted that hand clinic also has occupational therapy. Seems that patients with simple fractures benefit from this for splints, advice on activities, etc. Do you think this will be a loss if these families are triaged elsewhere? So I guess that kind of comes back to the simple care pathway as well. I think we're still working on that arm of the pathway. So right now we've created a risk assessment tool. So this prediction model with all the tick boxes, this is just a small part of the pathway. So this is how we can help you guys triage the fractures. We're really working on what the heck happens after the fracture is classified as simple. We need to do a lot more work on that part of the pathway. We need to create educational resources for the patients and their parents, as well as support resources for the simple care provider, those non-subspecialists. So I do think that doing these qualitative studies and finding out more about this will be helpful. So comparing how how family doctors or hand therapists would manage that fracture and how plastic surgeons would manage that fracture, and then create educational resources around that. Okay, next question. This question is, based on your criteria, what proportion of current referrals are simple versus complex? Great. I think actually we're on the right slide to mention this, although it's pretty small. So right now, there's about 30% of the hand fractures that we know about are complex and 70% are simple. And then within that 30% that are complex, it's about 10% that go on to require surgery. Thanks for your question. One of the questions is that last Salter-Harris 2 example is angulated. What defines angulation needing referral? I'll try to bring up the fracture that we're referring to, or I think we're referring to at least. Yes, I think it's this one. Okay, so the question again is, this fracture is angulated. What defines angulation needing referral? I do think that this is probably a bit tricky one. So we would not define this as angulated, but I think probably that question is referring to the fact that there's a little bit of a curve or a bend here right above that. So I think that there's going to be discrepancies again, and we're probably talking about inter-array reliability again, between what plastic surgeons think of as angulation and what primary care providers would think of angulation, or even within plastic surgeons, what they consider angulation. Specifically for this model, what we defined angulation as was any angulation greater than 5 degrees. So previously we had divided angulation up into mild, moderate, severe, and given points for each of that. But when we changed into the point score system, it's just any angulation over 5 degrees. And just looking at our QI, like our prospective trial at ACH, right now it seems like people are using that predictor appropriately, but I do think that there's still going to be some predictors that we can't make exactly perfect, but it still seems to be capturing the types of fractures we want to capture at this time. The next question is, Rebecca, do you have a sense for what types of complex fractures were missed in the prospective sample? Yes, I do have that information for us, or a couple of examples of that. So in the prospective trial, I told you that the sensitivity was 90%. And another way to look at that kind of information is by a 2x2 table. So this 2x2 table, how you should be reading it is the actual outcome, simple or complex, is in the rows here. So overall, there's 163 simple fractures out of 205, and there's 42 complex fractures of 205. And then the columns here, they represent how the Calgary Kids Hand Rule predicted. So the Calgary Kids Hand Rule predicted 124 simple fractures, and it predicted 81 complex fractures. And the complex fractures that were missing, that's highlighted here in this cell. So the Calgary Kids Hand Rule predicted simple, but in reality, the fracture was complex. So that's the 4 false negatives. And because our numbers aren't that big, having 4 false negatives is actually like quite significant, and that's why the sensitivity is only 90%. Every time you get 1 false negative, it really bumps that number down. So for example, this is one of the false negatives. So this is a Salter-Harris 1 fracture of the left thumb. And you can see here that this fragment here, I would say, is angulated. And this fracture went on to have a closed reduction. So it was a complex fracture because it ended up needing a closed reduction. And this is the form that was filled out for the Calgary Kids Hand Rule, so the referral form. And here you can see that none of the predictors are ticked. And the physician who filled out the form said this was a simple fracture. So they're using the form correctly. And then the comments down here said, had the left thumb caught in a door jamb, abrasion over the dorsum of the thumb, and well-perfused distal thumb. The X-ray ? Fracture noted. This patient was splinted and wound care was given. So I think that sometimes we're just going to have some misses. So I would say that this is an angulated fracture fragment, or you could maybe even say it was displaced, but it wasn't caught. And then and maybe it was also open because they know that there is an abrasion. I'll just give you one more example of a false negative. So this is another false negative that was in the ACH prospective trial. This is a Salter-Harris 2 injury involving the right 4th distal phalanx, and the arrow shows where the fracture is. And this is the ED form. So none of the predictors were ticked off, but also that simple box was not ticked off. So this actually makes me think that the form was used incorrectly, and that if you didn't tick off any predictors, hopefully at least you tick off that simple box. And then if we look at this, you could probably argue that this fracture is angulated. And also when you read the comments, it says mallet finger, distal Salter-Harris 2 fracture, and there's a fingernail avulsion. So the fingernail is ripped off. So I think that could also fall under an open fracture. So these are the type of false negatives or missed complex fractures that we were seeing in the ACH prospective trial, to answer that question. Okay, the next question, and there's only 2 more questions here. Given virtually any simple fracture of any kind seems to be sent to the emergency department, it's very clear many family physicians are not comfortable managing fractures of any kind. What do you suggest for this cohort? Yeah, I think that's a great point, and that's something that has been coming up since we've been discussing implementing this pair pathway with stakeholders. So part of that qualitative study is that we've already started talking to stakeholders about how we would implement this pathway. And one of the stakeholders that we've been chatting with is family care physicians as well as urgent care physicians. And it was brought to our attention that there is probably about 1,200 family physicians practicing in Calgary. So they may only see 1 or maybe even none of kids' hand fractures a year. So this is a pretty niche topic for them. So they feel that they are not very well equipped to triage hand fractures. So originally, in our current pathway, we kind of have family doctors triaging these hand fractures, but in our proposed pathway, it's kind of more of a plus or minus referral here. We're thinking it's going to be more urgent care and emergency department physicians that will be using the Calgary Kids Hand Rule, because you guys are the ones that have those skills and see a higher volume of kids' hand fractures. The other thing that came to our attention was that family doctors don't have easy access to x-rays. And even if they send away a child to get an x-ray, they often don't have access to those images and are just reading a radiologist report. So they may not have the information to use the Calgary Kids Hand Rule as well. So I foresee them, the family physicians, they may not be a high user of the Calgary Kids Hand Rule, and it'll probably be more on urgent care or emergency physicians. So I think for family practice, there's still going to be a small subset that get managed by family practice physicians regardless, and maybe aren't even really brought to our attention or triage. the family practice is probably going to play more of a role in the downstream. So they might be one of the simple care providers, one of the non-subspecialists that are taking care of these kids. And here's our last question. The last question is, I'm guessing that you mean family physician follow-up when you say non-subspecialist follow-up. Implementation of decision rules in emergency medicine has shown that human psychology and behavioral change management are critical in implementation. Do you have any data about family physician comfort in following up simple, i.e. a score of 0, pediatric hand fractures? What support would family physicians need to be able to follow up on these? Well, this is a great question, and clearly someone that has an interest or some background in prediction model work, just from the word and the understanding of the implementation. I think this question is absolutely correct. This is going to be a huge barrier, the comfort level of the downstream provider. So we don't have a great sense of the comfort level right now because, of course, we're plastic surgeons. So that's going to be another key thing in this qualitative study. So before we just implement our Calgary Kids hand rule and think that it's going to work, I think this qualitative study is going to be really key in focus groups and understanding the needs of the simple care providers. And you're right, I think a lot of the care providers will be family physicians, although it also sounds like maybe urgent care physicians are doing some of their own follow-up. I know they are family care physicians by training as well. And potentially, at least at ACH, probably the hand therapists will be doing some of the follow-up as well, as they're already intimately involved with this patient population. So I think what kind of support the family physicians would need, they would probably need some educational handouts, not only to the patient, but also to that family care provider, perhaps a website, some CME teaching, and then it'll probably be a period of time and transition period before anyone's comfortable, an iterative process, and hopefully we'll find out some of that information in our future study through that qualitative study. Okay, great. So that's all the questions through the Q&A. Again, just thank you so much to everyone, one, for your great questions and participation, but also just to listen to this Zoom seminar for so long. I think that's all. I'm not sure if anyone else has anything to add.